Welcome to this session on drugs affecting the reproductive system, where we will have a look at contraceptives and hormone replacement therapy. First of all, the oral contraceptive pill, or OCP. It is the most effective form of reversible contraception. The way that the oral contraceptive pill works is to mimic the sequence and relative levels of natural estrogen and progesterone throughout the menstrual cycle. So you'll see when we look at the different formulations, it is very similar to the natural system where estrogen is low early in the cycle, high in the middle of the cycle, and in moderate levels later in the cycle. Progesterone, on the other hand, is very low to absent early in the cycle, rises mid-cycle and stays high for the second half of the cycle, days 14 to 28. During day 21 to 28 of the oral contraceptive pill, women take a placebo tablet, and this precipitates a menstruation, and it also ensures that at the beginning of the next cycle there is low estrogen and low progesterone, mimicking the normal hormonal cycles. The estrogen component in the oral contraceptive pill affects the pituitary and decreases follicle-stimulating hormone release. The effect of less follicle-stimulating hormone is that there is impaired selection of a dominant follicle in the ovary. Because there is impaired likelihood of follicular development, there is a decreased consequence of ovulation at mid-cycle. So therefore, if fertilization should occur, there is a decreased chance of implantation. Progesterone component in the pill modifies the secretory activity of the uterine cervix. It also decreases luteinizing hormone release from the pituitary and therefore impairs further any ovulation. In addition, it will impair the motility in the oviduct or fallopian tubes, and all in all this decreases the likelihood of a fertilization. So taken over a few cycles, the contraceptive actions of the oral pill become more obvious. It affects the hypothalamus and reduces gonadotropin releasing hormone. So therefore this will cause always very low levels of pituitary follicle stimulating hormone and luteinizing hormone, and therefore there will be very little secretion of endogenous ovarian steroids. With time, this causes a thickening of the mucus. This impairs sperm transport through the vagina and cervix. With time, it will also decrease the endometrium, so therefore, with time, menstrual flow will decrease. And this, all in all, reduces the likelihood of ovulation and implantation. But this also means that the pill can be indicated for much more than just contraception. The oral contraceptive pill can also be indicated for menstrual disorders such as menorrhagia, dysmenorrhea, polycystic ovarian syndrome, PCOS, and it's possibly useful in endometriosis. It does reduce the symptoms of premenstrual syndrome, and as we'll see later, there are formulations that can be used for emergency contraception, the old term, the morning after pill. As an oral contraceptive, an estrogen-like component alone would be sufficient to provide contraception, stopping that very first ovarian follicle from developing. However, you would need much higher levels of estrogen. This would increase the bleed in the second half of the cycle, and because of the higher estrogen, there would be a higher incidence of estrogenic adverse effects. So progesterone is combined with estrogen in the pill. This overcomes this need for higher estrogen and overcomes those adverse effects that would be linked with this. And it does actually mimic more closely a normal hormonal cycle. These formulations are known as the combined pill, where there is a synthetic estrogen, usually ethinyl estradiol, also known as menstruinol. The synthetic progesterone is the natural progesterone in these formulations. This progesterone component is inactivated by first pass through the liver when taken orally. So, because it's inactivated, it has a very low efficacy when taken orally. The other important thing to be aware of with oral contraceptives is drugs that will interact. St. John's wort is a herbal medicine used for depression, and it can lead to an adverse drug reaction type F, failure. So this would be failure of the oral contraceptive steroids in the pill. This interaction is still being studied to see whether it's a pharmacological or a pharmacodynamic interaction. The oral contraceptive pill should be taken at the same time each day for optimal contraception, and if breakthrough bleeding does occur, this would indicate that a higher dose of progesterone is needed, and so there are various formulations available for different women and for the different purposes. So different progesterones have different properties as well. For a woman, where it's beneficial to avoid weight gain, norethisterone would be beneficial. If a person is amenorrheic, then once again norethisterone would be the best formulation to prevent that adverse physiological finding. Cyproterone is beneficial for women who might have hirsutism or excess of hair over the body. It's also useful for women who might have acne or perhaps a very oily skin. And this formulation of progesterone is also useful for people who might experience breakthrough bleeding. We'll look at some of the formulations then of the oral contraceptives. The monophasics have a fixed ratio of estrogen and progesterone for 21 of the days, and then for the last 7 days the placebo is taken. It is found with these that you get far better compliance. There is less confusion if a tablet is missed. It is better at regulating the person's mood. And it's easy to extend the cycle if perhaps you want to then, after the 21 days, take another cycle of 21 days of hormone tablets. The biphasic formulations, such as biphasal, a proprietary name, is not used very commonly. The estrogen level is constant, but there is 2 phases to the progesterone: low for days 7 to 10 and a higher level of progesterone for days 11 to 14. So this is the normal blister pack for a monophasic contraceptive pill, where, as you can see, 150 micrograms of ethinyl estradiol, 30 micrograms of ethinyl estradiol and 150 micrograms of levonorgestrel are the active ingredients. So this is a synthetic form of progesterone and a synthetic form of estrogen. The placebo tablets contain lactose. There are triphasic formulations of the oral contraceptive pill meant to mimic more closely the normal hormone patterns that we discussed previously. Estrogens are consistently low. The progesterone in this particular formulation of the pill is phased 3 times throughout the course of one cycle. The incidence and severity of the adverse effects tend to be lowest with the triphasic formulation, so they are indicated for women where the monophasic formulations are not very beneficial for that person. There is also a mini pill, progesterone for all 28 days. It has less contraceptive cover. Remember, here we are only affecting the cervix and endometrium. So the exact timing of the dose is very, very critical to get the best contraceptive cover. There is more breakthrough bleeding with the mini pill, but it totally avoids any estrogenic adverse effects that a woman might be experiencing. So therefore it can be used in lactation, and the adverse effects of the pill, which we'll look at shortly, a lot of them are due to that estrogen component and include risk of thromboembolic disorders, so a mini pill would be indicated for these women. Also, there's a greater risk of these thromboembolic events in women who are smokers, and so the doctor might prefer to put them on a mini pill to avoid that risk. There is also a progesterone-only depot formulation, Depo-Provera, Eplanon, and other proprietary brands, where a little disc or a little cylinder is inserted intramuscularly. There is a disadvantage. It takes longer for normal fertility to return after that depot is removed. The adverse effects with these depot formulations include vaginal bleeding, irregular periods, and that unfortunate weight gain. Oral contraceptives have many adverse effects. They can cause headache, nausea, and fluid retention. For some women, it can be virilization, breast discomfort, and increased cervical secretions. It can bring on acne and depression, that weight gain we've already talked about, and it can make women more irritable. This is a general exacerbation of estrogenic and progestogen effects. The increased risk of thromboembolic events is the serious adverse effect to be avoided in some women. And then other effects. There is suppression of normal physiological hormone pathways. We said with time there will be inhibition of gonadotropin-releasing hormone, pituitary follicle-stimulating hormone, and luteinizing hormone, and so there will be reduced production of endogenous ovarian hormones, including estrogen and progesterone. But this may all have unwanted effects, such as discontinuation of ovulation after the pill is stopped, so difficulty with conception when the couple then choose to have a child. So it takes some time for the normal hormone function to begin again, leading to an ovulation and leading to a successful conception. It's also known that with time, the oral contraceptive pill can deplete B group vitamins. In the morning after pill formulation, we said this is emergency contraception. The term morning after has been misleading for some people. It's indicated for use within 72 hours of an unprotected intercourse where the woman does not wish to conceive. There could be many reasons for this, including if the woman was raped. So there are currently 2 regimens for the emergency contraception. 2 high-dose oral contraceptive pills, followed 12 hours later by 2 more. The other regimen is 1 750 microgram levonorgestrel, a high-dose progestogen, and then 12 hours later followed by 1 more high-dose progestogen tablet. These high doses of oral steroids can make the woman suffer nausea and vomiting, so an antiemetic needs to be taken. However, with the commonest ones available, they don't cause very good antiemesis at the time of vomiting. They are better given as a prophylactic to prevent vomiting. So generic names such as prochlorperazine, metoclopramide and so on should be taken well beforehand, before the regimen of high-dose contraceptive pills is taken. The emergency contraceptive pill prevents 95% of fertilizations within the first 24 hours, but the efficacy rate falls to 85% if taken 24 to 48 hours. So as you can see, beyond 72 hours, its efficacy would fall away, and it would be too unreliable as a mechanism of contraception. So 58% within that 48 to 72 hours, which is a little bit risky, and then beyond the 72 hours, much less than that if there was an unprotected intercourse.